Bill Gardner, who actually have you presented here before?
No,
you did.
I presented this
I know we've met a few
when I
times.
first came, when it was just a thought.
Exactly.
Now it's becoming a reality.
So yeah, so he's going to tell us about the new ECHO project, which is really exciting. So Bill is a child psychologist, and as most PhD psychology folks, very strong research methodology, statistics, and so on. Works on mental health services. He studies children's mental health interventions, and he's a professor of epidemiology and at the CHIO Research Institute and the University of, and he holds a University of Ottawa chair in child and adolescent psychiatry research. He's a senior research scientist at CHIO, where he directs the Center for Pediatric Mental Health Services and Policy Research.
Thank you.
Thanks. And Dr. Gardner works with Kathleen Pager,
Yes,
who is
and this is
unable to
our
attend.
joint work. Kathy Pager is Chief of Psychiatry at CHIO, and a noted student of the HPA axis, but I'm trying to slowly bring her around to health services research. Is a worthwhile thing to do. So, great. So this is about our new thing, Project ECHO, and Project ECHO is a larger movement, really, for the transformation of clinical care. We are setting up an ECHO, as they say, on child and youth mental health care for Ontario. And I have no commercial interests associated with this talk, but it occurs to me that I should amend that slide because, not that I get any money from it, we are now supported by a contract with the province of Ontario for the next 3 years to develop this. But it's actually the plan of it's not a research grant, this is a service, and I'll describe how it works, that is supposed to be although we only have 3 years of funding right now, it's supposed to become a permanent piece of child and youth mental health in the province. So that is an important thing to disclose. Okay. So first I'm going to describe what is Project ECHO. Second, talk about our specific ECHO on child and youth mental health. And then talk about research that we want to do on this project, which I hope some of you will be interested in perhaps working with us on. Okay. So, ECHO is a movement that originated and ECHO stands for, I always forget, Extension for Community Health Optimization or something. They basically picked words out of the air to make up the acronym ECHO because they thought it would work. But it is an approach to improving the care for the underserved. That's its big mission. It originated with a group in the University of New Mexico, and I'll describe that a little bit. They have an extremely ambitious goal, which is to affect the care of 1 billion people by 2025. And that sounds insane, but I will provide some data in a few slides to suggest it's not outside the realm of possibility. But let's look at the whole mission here. They want to get best practice care to underserved people all over the world. The notion is that there should be one standard of care, whoever you are and wherever you live. Now, there are lots of people who actually have that goal. I mean, if you're familiar with Partners in Health, the folks who, led by Paul Farmer, working in Haiti, that's very much their goal. Jim Kim, the guy who currently runs the World Bank, has a similar goal. ECHO has a particular view on how to get there. And it's captured in this phrase, to democratize medical knowledge. Now, what that means is this. There are lots of reasons why health is poor for many poor people. Many of which have to do with the social determinants of health. Some of which have to do with the lack of investment in infrastructure to provide good facilities for health care in underserved areas. And those are real problems, but those aren't the focus of ECHO. ECHO has a particular view. It's not that it's not that they think those things aren't a problem, but they're taking one particular slice of the problem, and the thing they're focused on is that most of the people in the world don't have access to good specialty care. Okay? Millions of people die every year of things that could be prevented if there were more general surgeons around. That could be prevented if there were people who knew how to prescribe available but relatively complex medications. The kinds of things that specialists are available to do for affluent people in metropolitan centers in the developed world, but are not available in large parts of Asia, Africa, South America, and in fact, North America. So what ECHO is trying to do is to provide, they have a particular take on how to do collaborative care between specialists and primary care providers so that people giving care in local communities who do not necessarily have the credentials or the education that would give them the skills to do some of these things, get them to raise the level of their practice in a supportive environment so that they can. That's not going to solve all the problems of being underserved, but to the degree you can do this, it's an extremely cost-effective way of approaching it. Now I'll try to spell this out a little bit more, but that's what's meant to be captured by democratized medical knowledge. It's rather than keeping specialist skills concentrated in a very few places that can have very fancy, highly specialized doctors, it's to bring that, transmit those skills out to where people actually live to deliver care in those settings. So the goal of Project ECHO is to develop a model to treat complex diseases in rural locations in developing countries. Okay. The application to Ontario, I hope, is obvious to everyone. We have an enormous amount of remote areas here where people can't get good care. And that's part of what we're trying to address in our Project ECHO. One of the really nifty things about being an American and coming here, I'm now a permanent resident. I'm very proud of this. Happened just a couple weeks ago. But is you're used to thinking of Texas as a big place. And it's really not once you get up here. New Mexico, though, is where this started. And New Mexico is a place that's quite poor by North American standards. It's highly rural. There's very low population density and very few roads. So that there's a couple of modest-sized cities, Albuquerque and Santa Fe, and then the rest of it's desert, and what in America is known politically incorrectly as Indian reservations, including a very large Navajo reservation, which is the largest indigenous group in the United States. It has also a large Hispanic population, and these populations are historically underserved, badly underserved. So there's a hepatologist at the University of New Mexico named Dr. Sanjeev Arora, and he had a career doing some studying cellular stuff in liver function. But he also was treating hepatitis C. Now, I kind of bet most of you are not in a hepatitis C world, but you probably also do know that it's a large problem. It's a chronic illness that leads to many deaths. It's also a disease of poverty, right? Transmitted through sexual contact, needle use, amateur tattoos done in jails. There were lots of HCV positive people in New Mexico, many of them concentrated in the prisons and in the Navajo country. And a tiny proportion were getting treated, and lots of them were dying. And, you know, hepatitis C then, and especially now, is a curable thing by and large, right? But the thing is, the drugs that are usable with hepatitis C are expensive. They have quite complicated side effects, and was something that primary care it's a form of treatment that primary care doctors were really reluctant to pursue. So lots of people were not getting treated and dying. Now, Dr. Arora and like 3 other people were the only liver specialists in the state. There was no possible way that they were going to be able to handle all these patients themselves. So the question was, and they all basically lived in Albuquerque, which is in the very center of New Mexico. I want to just stop right now and make an analogy to child and youth mental health. A lot of you some of you will know Paul Kurdiak, who is a psychiatrist at ISIS and sick kids, I think. He did this great study with people, 2 old friends of mine, Benoit Molsant and David Goldblum, where they looked at the distribution of psychiatrists in Ontario. And it's this really interesting graph where, I should have put it up here, there are 5 times as many psychiatrists per 1,000 in Toronto than there are but they may be 3 times as many in Toronto as there are in Ottawa. And there's like twice as many in Ottawa as the next most highly concentrated LHIN, and then all the other areas in the state have very, very few psychiatrists at all. And I'm sure the same thing holds with psychologists or any other mental health professional. So basically, we have a situation that's very similar. All the relevant specialists are concentrated in one or two urban areas, and there are vast tracts of difficult to reach places where there are children with significant mental health problems who have no access to specialized care. So this is in Ontario. Moreover, there have been many studies of primary care attitudes toward children. Most folks think it's a really important problem. I would really like to do something, but I don't really know what to do. Quite perhaps as severe as this, but of a reluctance I'm talking to you about hepatitis C because it's very similar to the problem faced, that we face here in giving mental health care to kids in Ontario. Okay, so how does ECHO take on this problem of getting one standard of care to people in underserved areas? Well, the first is they use technology to leverage scarce resources. The key thing that happens in ECHO is a kind of training program for primary care providers where there's an ongoing weekly case conference that's conducted over telehealth. And I'll show you a picture of that in a second. But they have worked very hard in developing methods for how to optimally use a kind of video case conference process to communicate knowledge out to people to help them and support them in raising their level of care. The idea is that you're going to share best practices. There's a two-way transmission that's going on. On the one hand, there's technical knowledge about how to give care that the specialists hope to transmit to the primary care docs. So the ongoing case conference will typically involve a panel of specialists who are interacting with people in primary care offices spread across an area. The specialists will involve, a panel of people for HCV. It's they typically have a liver specialist, a pharmacist, a psychiatrist, because an awful lot of folks with hepatitis who are hepatitis C positive have substance abuse problems or mental health problems, and these things often have to be treated before you can initiate antiviral treatment. And those folks are available to talk through cases. The thing runs as a kind of case conference where each week a certain number of the primary care docs out in various locations will present a case. It's discussed by the specialists and by their primary care peers. But this very strong view of ECHO is that the learning goes both ways. That even though the specialists are the ones who get a certain deference because of their technical knowledge, there's a deference that goes the other way because it is going to be the local provider in a community who understands the patient, first of all, but second, understands the culture of the milieu from whom the patient comes. And understanding that and putting those different pieces of knowledge together, both the technical knowledge about the best care, the best practices, but also what is the appropriate way to deliver care and to sort of elicit engagement from the patient is the kind of thing for whom the local provider is going to be the true expert. And that good care involves both of these kinds of knowledge standing on an equal footing. This is a second meaning of democratizing medical knowledge, but I think is extraordinarily important. One of Dr. Aurora's slogans for all of this is that the key ingredient in ECHO is respect. The idea, first of all, respect for the patient, but also respect going both ways between specialists and primary care providers. The notion of learning in ECHO is not primarily didactic. Most continuing medical education programs, and I'm satirizing a little bit, but kind of involve putting together a lot of reprints of papers and nice little flowchart algorithms in a 3-ring binder, giving it to people basically during a 3-hour workshop and say, okay, now you're up to speed. There is a piece of that in ECHO. If you're doing ECHO as a primary care doc, you sign up for most of a year of participation, weekly sessions, and it begins with what we call a boot camp, where there is a kind of didactic training session, but the main thing that goes on is case-based learning or learning by doing. So you present a case, you discuss it with your peers and with the specialists, you go back and try it. Later on in some number of weeks or months later, you come back and report how it worked. And everybody actually learns from experience, not having been to medical school, and many patients are better off for my not having gone to medical school, I'm quite confident. It was a joke. By the way, before I became an academic, I did a little school teaching, so I'm used to people interrupting in inappropriate ways at any time. So if you want to ask, and I should have said this at the beginning, just say something. I can answer your question. One of the things that immediately appealed to, yeah, please.
So I'll interrupt. Two thoughts have sort of come to my mind as you speak. One is, you said when you were talking about the hepatitis C example, that, so primary care docs are not necessarily comfortable treating this, and I fully agree. I think there's another dimension to this, and then I think my understanding is it's even more prevalent in the States than here, but it's the whole medical legal aspect of what is outside your scope of practice, and how to keep, take that into account. And I mean, clearly having the support of a specialist certainly adds confidence as well as makes it medical legally more
Well,
acceptable, but I think
yeah.
that's something that needs to be, I'm sure you've taken into account.
Well, yeah, I mean, no, I probably wouldn't be a person who'd have the sufficient expertise to comment on that, in the sense that, I don't know great detail about the malpractice situation or anything that governs folks. There's obviously no legal obstacle to somebody prescribing one of these drugs.
No.
There's a concern that if it goes wrong, they might be sued. It's kind of funny.
I'm saying it not
Go ahead,
so
okay.
much as I don't think it's necessarily a barrier for the people who are, let's say, participating in this kind of a program, but I think it's a reason why this dissemination of knowledge hasn't happened more before.
Yeah.
It's not because people are not capable of acquiring the knowledge or putting it into practice, but I think that aspect plays a role in reasons why you have 5% of your HCV patients treated and not more, right? I think it's just sort of one of the factors. So I might be wrong. It may not be relevant.
No, it might
plays a
be.
role. The other comment I wanted to make is when you mentioned, a one-year program, one time, once a week seminar or something like that, and I'm just kind of going like, oh my God.
Yeah.
I think about everything else that I need
Absolutely.
to do as a family doctor.
Right.
And then this is, somebody's pet disease. Well, there's like 50 other pet diseases out there
Right.
that are also orphans that somebody else also wants to have shared
That's a
care.
really important point.
So we have to also look at the prevalence, I think, and the importance, like the burden of disease in the population at hand in order to choose what the priorities should be.
Yes, so let me address that one because that's an incredibly important point.
Can I actually make a suggestion? Because I think the intent is at the end for you to have a discussion with the group about their interest in this. And so people might actually raise a number of sort of questions or, limitations that they see, and then we might want to address them. I mean, if you want to address it now, but I think there are going to be, discussions around, well, how does this apply to us and what can we do and what we can't do?
Fine, let me just address that one though, because the question's right there, and it's a great question. The view of ECHO is absolutely not that every primary care doctor would become an expert in HCV. That's kind of crazy for just the reason you mentioned, because there's so many different things that, it would be an entirely different education. Nobody could be expert in every relevant disease. The idea though is that you could have many communities where amongst a group of family docs, there would be one or two who could become expert, who could become the person who, in that community, you could go to if you were if you were HCV positive. And then the idea is that only a very few people are going to have the interest or think. And by the way, it's not that anybody ever shows up every week, right? But the idea is that you have a node of people, and there's enough participation in any given week to have a rich discussion, and things roll along. Everybody understands that there are barriers to participation. There's incentives, there's CME, and it's free. So, but everybody recognizes that the primary care folks have got to make a commitment through the volunteering of their time, which is quite valuable.
Well, I'm just going to say that there is a Project ECHO in Ontario.
There's several now.
Yeah, because there's the addictions one. So I think you're raising the issue of what is the thing in my practice that worries me the most,
Right.
that I will make the commitment to that time to learn.
Or that you have the interest, or for whatever reason,
So
right?
it's about finding the right
The right person.
and it's not everybody that's going to do it. And
Yep.
in fact, in Ottawa, with the high number of child psychiatrists, people aren't going to do it here, but they do need to do it in those communities where they have zero access. And I think the piece that you're bringing up that's different from e-consult, which we're already using, is the supportive aspect of this. It's, as you talk about master complexity, it's, you know, it's not about one patient with one answer, it's about that supportive group. The other thing that strikes me is that we, in primary care, have something called small group problem-based learning.
Mhm.
And family doctors get together with cases. It's not as directed as this, and it's not specialty driven. So it's just the family doctors, but it is that piece of support and discussion that, you know, we hear all the time is missing because the doctor's lounge is gone. So this is how to bring us back together with a group of specialists and family doctors to get the support. So I think it's trying to tease out what are the differences of the opportunities. And I agree that, you know, when you're on one aspect, it's, you know, you have to be committed and interested because there are so many other things we could do. So I think it's important to know that it's here. It's not as if it's brand new to us.
Yeah, this is a question from Dr. Claire Liddy.
Oh, yeah, please.
She's online, and it's related to this topic that you're discussing. So she also is wondering how about you go recruiting the right kind of specialist who will be respectful of the primary care providers, and then do you have a quality monitoring of the echo sessions?
We're trying to learn how to do recruiting best, and one of the reasons I was eager to present here is to get ideas from all of you of where to look and get the most exposure to the people who might be most thing. Are we the kind of specialists that have the sort of quality of respect? I hope so. We do have various quality monitoring things we're planning to build into the sessions. So, oops.
Bill, can I just ask you, do you have a family physician on your committee?
We had several help us write the grant. The panel sitting in the front of the session, and I'll show you the picture of this, right now does not include a family physician. But that's something we'd be happy to discuss, whether that would work well.
Well, if they aren't at the table, they're the receivers,
Right.
not the collaborators.
I don't think so. I mean, I would love to be able to show you a videotape, but I mean, I think that the whole thing is built so as not to talk down, if that's what you mean.
So Bill, we have 20 minutes left, or 15, 20 minutes left. So it's a trade-off between having the discussion now or getting through a couple of points.
Okay.
Just maybe 5 minutes to get through your points.
Let me blast through,
So
okay?
that they're,
Please save the questions. Okay. So here's a picture of how the session works. This is actually Dr. Aurora here. These are some of the other staff at the Echo Center. They're running right now an HCV consult, and a screen like this will be at the front of the room, and these are different primary care offices at various locations across New Mexico. And when the way the system works is that whenever one of these folks is speaking, the software brings them to the center and so on and so forth. And it through many thousands of hours, they fine-tuned a really good set of stuff here. Overall principles of ECHO: there's only one acceptable standard of care. Local care is the best care. The idea is to bring care to the patient. You don't have people driving in from Farmington, New Mexico, up at the Four Corners to Albuquerque. Care travels to people rather than vice versa. And the idea is to transform the role of the specialist from being, simply an authority who's better paid to becoming a teacher and a learner. So how well does ECHO work? There's a lot of evaluative research that's been conducted on PCP's reports of their learning. There's one really good study of patient outcomes, and there's stuff on the growth of the model. So summarizing many, many studies, this is just one. The self-reported effects for PCPs are quite large. The more important thing, though, is a equivalence trial design that was conducted in New Mexico, where they compared HCV care done by PCPs out in the dispersed areas to inpatient HCV care at the University of New Mexico. It was an equivalence trial. The idea is to show that there was no difference. The endpoint being getting people to the fact where there's no detectable virus. Basically, they were able to confirm the equivalence. In this case, non-significant p-values mean that the rates of clearance of the drugs were the same for both conditions. And this was published in the New England Journal. These are data that haven't been published. I actually just ran them myself in the last little while using data that Dr. Aurora supplied me. This is the growth in echoes starting in 2003. That's an exponential curve fit to the data. The thing is currently growing at 48% per annum, which is a doubling time of less than 2 years in terms of the number of centers doing this. If you take success and implementation as diffusion of ideas, ECHO's doing it right now. Now it's an epidemic model. Obviously, at some point, the sigmoid curve hits because there are only so many doctors to get engaged. But I think this is quite impressive. The growth, this is the growth in the number of countries where echoes are being done. And if you think in terms of the rate of increase in centers that are being formed and the number of doctors who are engaged in each center and the number of patients who are potentially affected by each doctor, the notion that you could affect 1 billion people in a little bit more than a decade isn't entirely outside of the bounds of possibility. So what are we doing? We're just starting. We're still planning our curriculum. We were just funded a couple of months ago. We're hiring staff. Our goal is to teach practitioners about the use of medications and brief interventions for kids. We are also going to develop a database, they actually capitalize on databases that already exist, but have locally expert system navigators who can help primary care docs figure out where other available resources are that they can send people to. In an extensive amount of research that Dr. Pager led when she was doing the strategic plan for CHIO's mental health program, that was this thing that came back over and over from primary care docs. We don't know where we can possibly send anybody when they have problems. We're going to start a hub in that is one of these key groups in the Champlain-Lynn sometime in this winter. We plan to roll this out across the province and to Nunavut over the next 5 years. What we offer is what amounts to a mini fellowship with CME at zero cost. There will be a 2-day boot camp that we will organize where you get a kind of basic training in child and youth mental health. You get to participate in the weekly tele-echo clinic. There'll be a brief didactic session at the very beginning, then collaborative problem solving and case-based learning. And you can come anytime for as long as you want. The specialists will be a psychiatrist, a system navigator, a person who really knows the local resources, a psychologist, and a substance abuse expert. The team will be available by telephone or email for emergency consultations outside of the ECHO session during business hours. And we're hoping to use this as a platform for conducting research. Topics of interest are learning by physicians who are participating in what have people learned, and that's also our quality control in part. We hope to use ISIS data. This is a long shot, but whether it's possible to see any changes in the use of pharmaceutical medications among indigent people and in the use of mental health services over time as we roll things out. We hope that we can find qualitative researchers who are interested in looking at the interactive processes in ECHO sessions. I have a side career where I write on moral philosophy, of all things. I think the notion of the democratization of knowledge is a very, very rich, powerful topic, and I have a paper going on that, and I hope to write more. So it's not standard medical research, but it works for me. What do we want from you, people in this room? We'd be very pleased to collaborate with anyone who's interested in our topics on this. We hope this to be an open platform where people who want to do this kind of research can work with us. We're looking for suggestions from you about how we can best get our message out to primary care providers who might want to participate in an ECHO. And if you personally, in your practice, want to be part of this, please get in touch. So you can reach me at CHIO or Kathy at CHIO. For better or for worse, I'm also available on Twitter. That's a good place to reach me. And I write on health policy at this blog. So that's me.
Terrific. Thank you. I'm sure there's going to be a lot of discussion. Help facilitate. I think Kevin, you. Oh, was it? No. Was it Kevin or was it Doug who had his hand raised before? I think it was Kevin.
Yeah. Thank you. Thank you very much. I'm just think this is a great model, and I think this is really important. I have two comments. One is that your idea of distance. I feel like I've let distance go as a barrier a long time ago. So underserviced, even in Ontario, is in the cities.
Oh, absolutely, sure.
Psychiatrists will not see anybody that doesn't fit their.
No, I agree 100%. And I should make that clear. Yes,
because I think
thank
the
you.
distance thing is just like for a lot of us, we work with underserviced populations, and they're happening right in the cities.
Absolutely.
So I think, but that's okay. So I like that. I find I'm trying to stay open, but I feel like you start with the evidence, which is with the specialists, and the specialists will want to share it with us. And as a family doctor, that resonates really poorly with me.
Okay.
So I have just had to tell you this. So you
No. This is the first time I've done this kind of version, so this is very helpful.
Specialists. So I guess we're doing the opposite with refugee health, where it's family doctors leading the specialists for some of the care. So I'm not saying that, but it doesn't matter. So I don't want to get into that little bit of that's a problem. Although I think it's really important because it makes it hard for me to jump into your camp. Because I definitely believe in this camp of specialists and generalists working together and democratizing evidence not to family docs but to the patients. That's where I definitely go with you on that one. But I don't think democratized to me, I'm okay. I guess I work with specialists enough that I don't feel an issue there. But I definitely would like my underserviced patients to somehow get access to things, and it could be knowledge in their own perceived format that allows them to look after themselves. And that's just my
That's
comment.
such a helpful comment. Thank you very much.
Doug, and then there was Sharon. Did you have your hand?
I have a comment, well, I have a comment,
Oh,
but
sorry.
I don't,
Sharon,
no,
and
no,
the other Doug.
he's got it.
Okay, Sharon and Doug, I know you both had your hands raised.
So thank you for the presentation, and so you know Claire Liddy, who's on the screen, I guess, who we work with, and I think I have the dubious honor of being in the site in Ontario, the practice site that uses the e-consult site she set up the most. What's unique here is you're offering a multidisciplinary consultation, and at first when you presented the model of Hep C, I was sort of saying, Hep C is this, like diabetes, etc. You're dealing with child, youth, and mental health, we're dealing with families, we're dealing with instability. But there are a lot more parallels between Hep C and that, and certainly diabetes. And offering the multidisciplinary consultation is unique. It's not something that we have as part of our standard easy access arsenal of tools in primary care. So I think that's a really interesting aspect to continue. You did mention knowledge of local resources, and that to me is, that's the screaming piece you've heard is missing. And how you will get that without sort of a local partner, but ensuring that there is constantly updated two-way exchange of what are the local resources, I think will be fundamental to the sustainability.
And it's going to be a challenge too. I mean, we have a couple of strategies. The first is that we're going to start here in the LIN, and we know something about that. We're in contact with a lot of the different, YSB and similar folks in other regions, so that we have a place to start there. But yes, every time we move out, we're going to have to do the same sort of building process. Now, one of the great advantages we have is a close relationship with the Center for Excellence in Child and Adolescent Mental Health, who have got a whole staff of people who are working with the lead agencies for the MCYS world in all across the province. So that gives us an entree there. But we're going to have to develop a way to spin up local knowledge and find local people to work with as we spread out. It's going to be a real challenge for us.
Can I just continue on that thread, because this is something I wanted to raise. So we have what I believe is the first project in the province, maybe not, but at least in the Champlain region, where that system navigator is actually a generalist system navigator and attached to the primary care practice. There are so many navigators that are specialty specific. So your navigator is going to know all about the mental health, and some other navigator is going to know all about Parkinson's, and it becomes difficult for the primary care provider to have to know all these organizations. I really think the solution is to have systems navigator regionally, and that way that navigator can be regional and can understand the local context. So we're introducing the navigator randomized controlled trial starting this coming week, it's coming year, sorry, in about 3 months. And so maybe you might want to consider
No, I think we should talk more about that. That's a really interesting idea.
And I think it's particularly relevant here because of the comorbidity, not just within the individual child, but within the family.
Sure,
So
absolutely.
you're not going to get the
Can I
child
ask
better
what
when there's
data-
untreated illness in the parents.
What database did you say a whole bunch of databases that exist?
Well, I mean, there's something that, I kind of run across one sort of every few months, it seems like. I mean,
You're familiar with 211?
no?
Oh, we should talk. Okay. Is that related to this?
Yeah, so
okay.
Dr. Claire Liddy agrees with you, Simone, and then she just wanted to comment on Dr. Toddy's comment. She said, I think as Kevin said, the key is to try to bring in the lens of the patients and primary care and learn less about what the specialist needs.
Okay, so I must have done a poor job of presenting this if that didn't come across, but perhaps I have something to learn about how to do this better.
Yeah, just to follow up on that, I went to your launch.
Yeah.
And it was at CHIO.
Yeah.
And it's pediatricians, with specialists. Again, it's telling family doctors what they're not doing properly. So and it's not the message you're intending, and I understand that, but it's just like going to CHIO. If I want to refer a patient to CHIO, I send a letter, and immediately I'm sent back an intake form that they want me to fill out. The issue there is, that was your intake form that you're telling a family doctor we need. I ran into this at North York. Psychiatry sent out a new intake form. They did not include a family doctor on developing that form. So it was imposed on the family doctor. You can't have my service unless you do it the way I tell you to do it. The collaborative approach says, will this form work for you? Let me know if it's working. So I think that's the piece that you want to hear. And when I was pleased to hear that you said family doctors were on your grant, to engage them on your team is to have that respect. It's the respect that what I'm offering you, here's what works for you as well.
Yeah,
So
and also improve feasibility, because how many of these
Yeah.
forms do you have? Well, like, 50 different specialties,
Yeah.
or so imagine having to,
every specialty wants us to
Exactly.
own form.
yeah, exactly. Yeah.
Okay, so there aren't forms involved in this,
No,
right?
no, but CHIO has a form. CHIO has a form.
No. I think that your point is well taken, and
We're putting you on the spot there.
no, but it's like I'm unclear what I'm imposing on a doctor in this case.
Yeah, no, I
We can talk more on the break, I think. It'll be a
Okay.
good
I
opportunity.
think
So,
they-
yeah, maybe Doug.
Yeah, thanks, Bill, for the presentation. I was really interested, in when you put up that last slide with the qualitative research and the interactive process.
Yeah.
Exploring those.
Yeah.
This is certainly an interest of mine.
Great.
That's our education researcher.
Yeah, I'm an education researcher,
Mhm.
particularly interested around technology and education and how we learn with technology and in virtual environments. And you're probably aware of this, but using some guiding frameworks that are in existence. One, of course, is connectivism, right? Where we learn from our relationships from the various networks that we establish, but also community of inquiry. And hearing around, about having the perspective of the primary care physicians and the patients front and center. Community of inquiry sort of embraces that. There's this element of social presence, right, where everybody has to have this equal contribution in promoting the educational experience. So happy to chat with you more about that.
No, I'd love to. I mean, no, I don't know most of that stuff at all. I mean, I'm a ridiculously quantitative, narrow person, and I need all the help I can get on this. On my home planet, we don't have, kind of social constructivists. So, please.
Doug?
I want to defend Bill a bit, actually, but being beat up a bit.
No, this is so helpful.
This is what I see from this great about the project. And I think like Claire Lily's project about e-consult, it drives me crazy that you can't talk on the phone anymore with someone.
Yeah.
And because we can't, that rupture has happened, that you can't talk with a specialist or your colleagues on the phone. We start referring more quickly. And then Claire brings in this way that is a modern way of dealing with this rupture, this asynchronous approach of e-consult. And I think, I'm not sure if it was you or Diane was saying, this idea that we used to go to the doctor's lounge, and we used to have this conversation together, and that's been ruptured. And we need to, I like how you said we need to reach back and redevelop what we've always talked about in medicine for hundreds of years, about how we work together and have a modern way of dealing with this rupture. And I think that concept of that, like what I would love to see, this concept of that medical lounge where we can discuss things again. And it could even, this idea that, distance, where, whatever, where it can bridge, the medical lounge can be larger now, can be worldwide. And I think if it can bring back the heart of what we have in medicine in a modern era, which has been ruptured, then it'll be a success.
So one last comment, question, Sharon.
These were answers, you had two specific, one question was how to get this out and get involvement. And the reason I'm raising it now is there's an opportunity, for this region, there's the annual update course, and it takes place in April and May. And right now they're inviting speakers. These are your people. They're all
Okay.
family physicians, nurse
The
practitioners.
primary care
Fantastic.
forum as well at the LIM.
Right, so these are two examples, these are your people, they are there, they need presenters, this is when you do an update on mental health and this service, and that's your
That
audience.
sounds fantastic.
One of the
What a
most
great
efficient
idea.
ways to reach them. They also they'll come up afterwards, you get the personal relation, so it's a very effective way
Great,
to engage in something new, clinically related.
great.
My last comment wasn't in response to one of your questions, but looking at the outcomes, there was the patient-related outcomes, patient-reported or community-level outcomes are missing, and I know those are harder and messier, but this is about increased uptake of local resources connected to local services, sort of that sustainability piece, and possibly impact on community as well. And just having worked with some of the rural Eastern Ontario communities, this is something that is near and dear to them. Do they have to keep coming into Ottawa?
Oh,
Can
yeah,
they get there?
absolutely.
And so looking at the impact on that and how you built the communities through this partnership.
Well, so we're not funded for research by the province. We're funded to actually do this. We have a parallel thing in line to try to get some research funding. This is one of the reasons why I said I'm really interested in talking to people who would be interested in doing research, because that's a great idea. A qualitative study would be a great idea. I'd love to pursue these conversations further.
I think it's a great platform. So we're gonna need to cut it to make sure that we have enough time for the second speaker.
Yep.
I want to thank you very much. And actually, I think all the comments, it just shows a lot of engagement. So I think there's a lot of interest in this. And I know I brought it up to our departmental advisory committee, actually, I mentioned, and there certainly was some interest in there. But the interesting thing as well is that the first comment was, well, is there a family doc on that group? So I think
No,
that's something.
That's
so
a real takeaway, yeah,
we're
sure.
taking that away. Thank you very much. I think
Thank
that
you.
was. So, folks, will take 7 minutes. Okay, I will be bringing. Sorry, Claire. Tell her I say sorry. She can send him an email.
No, we talked with them extensively at one of the well.
Yeah, and they have meetings sometimes.
Yeah.
It's yours.
So run out to fix the computers and there because they've got enough.
Right.
And they have this in different regions, so as you're rolling out to different regions and looking at your local regions, these are effective ways to get the word out and position yourself among them, outside of them, so I think it's a great model.
Lamont, this is
Yeah.
one website that I'm going to use. Like, there's a password.
Okay, so let me.
Yeah.
We're saying this is what we're used to. We've been burned before by the sort of specialist down approach. And
We're sensitive.
we're sensitive, so you're dealing with sensitive people who need sort of a little bit of extra explaining and practicing approach. Because that's the standard thing is, okay, the specialist, even these refresher courses.
But it's the
It's
expert
the
model, like,
cardiologist, it's the blah blah,
it's
standing
the
out there saying,
experts
this is
telling
related
telling
evidence.
generalists what to
Exactly.
do. And that's the
That's
expert
what they
model,
have
whereas
done.
evidence-based guidelines is a totally turnaround of that. So
Yes.
you're kind of coming from a little bit of an older school there, I think. Although a lot of doctors are
After
still
lunch,
happy,
that's-
but in some of us aren't.
That's all. But I don't see that.
Because I guess you just gotta.
Explain that.
Well,
How are we not going to be evidence?
Well, see, part
Well,
of
because
this-
you didn't say it once in your whole talk. I was waiting for it.
Oh, okay.
So I didn't hear any evidence. I heard the experts are gonna bring their knowledge and democratize it, just as the lowly family docs. You
But
said
then,
that,
but then I also
When
said.
you said that,
but I
that was
said-
like really bad.
But I also said that the learning goes both ways, that
Well,
that
it's
the
not
knowledge of
that.
the local community.
No, it's not just law. I bring RCTs for my work to the specialists. And we look at them together.
Dr. Manuel.
We determine what's the best treatment. It's not the community stuff.
So your
that I
work
bring.
page
I
and
work
work
with
so you go beta.
levels of
Yeah, it
guidelines.
wouldn't take it.
It take, oh no, just, yeah, go there, beta dot, and just wait a minute. No, sorry, dot. Here, let me, I'll do it.
Yeah, we're trying to argue that it's a little different.
Oh, I put an extra feet.
Yeah, and it's gonna take a while to,
To load?
yeah.
Oh, yeah. We always have,
It's gotta spin up the servers.
Okay.
It'll take,
But our online guests won't be able to see it.
okay, they don't see the screen, they just see the,
No, they.
we can't go to the website within the,
The Adobe
Adobe?
here.
Yeah.
I don't know, I've never done it before.
We always know we need
All right, so let me just say one thing.
So you're here today.
Oh,
are you? Exactly. No, you know what? That's fine. Oh, that's fine. That's fine. I wanted to have just a quick chat with you before we proceed to the.
Yeah, exactly.
So we can do it. That's fine.
when I think about
And just, so we're doing this for.
Yeah, many evidence do not have.
And also just another
Okay, so I think that there is,
What is
I
that?
think,
They don't want to they want to know, the findings and how they might use them, how it might impact, how could you then address those? I know that goes beyond, but I think the intent
the
is to say,
idea that specialists.
you know, how is your student going to inform what they hear? And that's, I think, a lot of So I just wanted to make sure that we have that.
I think what I was there's two things I was and I have had like
Here's where I am.
I'm okay.
This is what's not working. But not everybody does.
Yeah.
And partly because it's the specialist's fault, they have not been available.
The other thing is the last part of this, I was thinking about presenting, like how we can get analytics into, like how we do policy analytics.
Okay, everyone, I'm gonna ask that we review. That's what happens when we don't have long enough breaks. Where's my computer?
It's double negative.
Okay, so I'd like to introduce, well, someone who really doesn't need a whole lot of introduction.
He'll want this stuff.
So you all know Doug. He's a family physician, has a degree in public health and preventive medicine. He completed his medical degree at Dalhousie and then worked as a general practitioner in northern and remote communities. And I guess that's where he developed his interest in equity and social determinants of health. And so his research combines his interest in public health, healthcare system, and primary care. The overarching question that spans his research is how to most effectively improve the health of communities and reduce inequities. So he's interested in assessing the real world effectiveness of strategies and intervention. And so he's going to tell us a little bit about his tools and his approach to identifying risk factors and to help motivate individuals to take their health promotion in hand. You should also know that his current practice is at the Ottawa Newcomer Clinic Centre, the healthcare point of entry for refugees arriving in Canada. And he's had multiple publications, over 150, and he's just recently had his full professorship approved.
Iman, who's on, how many people are on line?
Two, Dr. Liddy and Cindy.
Okay, this is going to be a little bit different for me, less about the actual research and a little bit more using some about where we're potentially going with big data and personalized medicine, presenting some other folks' research, and then the last third is presenting some of our work, our research. So, Iman, how am I going to do
Try it now?
Okay.
Yep.
These are the three things I'm going to talk about. One is, have we always been patient-oriented? Have we always been personalized? And what's all this new talk about? We're just revisiting what we've done in the past? But given that, what are some potential opportunities or challenges with the kind of current thinking of personalized medicine and where big data is? And then just a quick kind of snapshot overview of some of the direction that we've been taking, more actually from a family medicine perspective than a population perspective. That's what I'm going to be talking about today. So precision medicine, this is the wiki definition, which is consistent with most, but precision medicine, medical model that proposes customization of healthcare with medical decisions, practices, and products being tailored to the individual patient. So not one size fits all, but listening to the patient, figuring out what their issue is, and then tailoring that for that. So personalized risk assessment, personalized risk communication, personalized interventions. I think we can agree on that. Again, part of it, this presentation is just kind of revisiting the definitions and seeing what the definitions are of big data and what the definitions of all this talk is and how it relates to family medicine. Personalized medicine. So again, not one size fits all. You can stratify patients into different groups, ideally as small as groups as possible. So again, you're tailoring it as much to that person, like instead of saying we're all the same, in what ways are we all different in this room? And how does that influence our medicine or not? And a lot of predictive concepts in there, and which is of course what we do quite a bit, what I do quite a bit. And patient-oriented. I was looking in Wikipedia, no definitions in Wikipedia for patient-oriented, but this is CIHR, this is our funders, right? So, and with the big SCORE initiative, and this is right off their definitions. Patient-oriented research refers to the continuum of research that engages patients as partners, so just putting patients first. And a lot of the related concepts that we see that are being talked about are things like PROMs, patient-recorded outcome measures, but that's idea of just putting patients first at the center of this. So those are the three definitions. So I guess what I'm saying is, this has been the cornerstone of what we've talked about in family medicine since family medicine started, and even before we had formal family medicine. So the classic 1929 Saturday Evening Post, putting the patient first, listen to what the problem is with the patient, and making it very personal, and tailoring your care. So, that when we see patients, the encounter is different for every patient. We're constantly tailoring our approach as we see that patient. And I think family medicine, not only family medicine, but I think family medicine really epitomizes that concept of listening to the patient and listening to what their priorities are and addressing them, whether it's the doll or from the little girl or what. Would you guys agree with that? Like, do you find a little bit like, what's all this new stuff about? Isn't this what we
Well,
proposed?
in oncology, for example, it's very different now. I mean, it's about targeted therapy.
Yeah.
Based on the molecular composition of the tumor. So in some areas of medicine, it is new.
I think personalized medicine, precision medicine, like as Obama presented it,
Yeah.
was this oncology, genetics, and medications that are tailored to it.
Yeah.
I think the definitions are quite clear. Like you look at all the definitions, it doesn't necessarily talk only about genetics. And again, isn't this, like from family medicine, we'd say it's social too, right? It's like listening to the social, we know their past history and things like that.
Yeah, I think it's one of those things that, we went to the guidelines that you apply to everyone.
Yeah.
And then there was a movement, I was in England a few years ago, where they were talking about values-based medicine.
Yeah.
So you take in the patient values. So that takes us back to personalized. But I think there was a shift to, and we still have those drivers.
Yeah.
You need mammogram whether you need it or not, or want it or not, because you're in this age group and somebody's going to pay you.
Yeah, so do you have similar thought?
No, I was just going to say, when I looked at those definitions, there isn't a notion of social, even though you say it, and I think many family doctors do take into account the social. Those definitions, if you look at them at the surface, I don't think that they encapsulate all of what you're saying. They all talk about individual and risk management and disease management. If you think about sort of the broader context, I'm not sure that those definitions capture it.
I think it's been debated, right? There was a New England Journal of Medicine editorial shortly after Obama announced it, talking about some of those. They're just like that. This needs to be part of it, and a bit critical. And there's recently a JAMA article again talking about the limitations, or that again we just does it or does it not encompass a population. I think population health folks have a lot of concerns about this. Not only like the idea that it's going to suck the air out of the room, and that we're going to miss our population-wide interventions if we're just trying to talk about a very personalized and individual approach. But I think, so moving on then, I think one of the themes from this morning, and I think that what I was talking about as well, is that there's been this, so maybe that was our ideal of what we had, but there's been a lot of pressures, I think, to take us away from this personalized approach. And I think Diane said one of them that I think is very clear, that there's been this more standardized approach. And I think that when I've been talking about this with people, they say, and I said, family medicine has always been this. And they go like, it's not that now. That ideal has been ruptured, that we've been having a lot of challenges with this. And I think things like this routine guideline treating everyone the same. I think there's been three issues that I would propose to you. So this is Saturday Evening Post as well. And that image of us as being this caring, patient-centered doctor, it's always, there's been some problems with this. This is the doctor who smokes Camels while he's studying at night. And historically, so these are the three things that have happened that I suggest to you that I've heard. One is that technology has been the savior, but also a burden. So that getting stuck on the phone. The other is that this doc was probably not that evidence-based and effective. And so we brought in all these things, guidelines for mammography or whatever, to try to make it more evidence-based. So that listening to the patient and tailoring it needs to still be informed with evidence. It's just like that doctor is not probably going to save that doll's heart. Even though they're well-intentioned at putting the patient first. So that was the concern, that we haven't been evidence-based in our patient-centered and personalized approach in family medicine historically.
And an assumption when things that are evidence-based are not done, it's because of poor performance.
Mhm.
rather than the flip side, it's because of inapplicability of that particular standard to the situation. There's sort of a global assumption, if X rates are 60%, it's because we're not properly treating
Yeah.
40%.
And
And we've nuanced that, but that
Yeah.
is the assumption.
Yeah, I think that's very true, and I'm just telling you what I'm hearing. Like I think these are some of the pressures that have had on us that have been pulling us away from that that historic kind of touchstone for us of being really patient-centered and being personalized in our personalized approach in family medicine. So now we've got to have all of our diabetics, hemoglobin A1C of 7.0, and even though that's probably not appropriate that's not the most important thing for some of the diabetics, right? And we want to deal with their social issues as opposed to.
And all
And that's gonna
diabetics are going to the natural path.
Yeah, and that's going to be a more important thing. So we know this in family medicine, but that I think the pressures have been pulling us to this guideline, this sort of more routine and then technology getting stuck on, like for all of us, we're getting stuck on the line with Bell Canada while they're trying to improve efficiencies and reduce costs, and it's being much less personal than it was. Our encounters in society, and I think the concern is that our encounters, even in family medicine, in medicine, there's these pressures that have been making it somewhat less personal. I think the third one is efficiency. And again, like that, Bell Canada trying to be more efficient by putting this on the robocall, and we've had tremendous drives to be more efficient, quote unquote, more efficient family medicine, so less time, more routine care, and things like that. I would say that's the three that I've heard, and I'm not sure how those resonate with you. So, some technology that's been rupturing it, and then this idea that efficiency and effectiveness has been making more sort of standard care as well. But I think still, like when we see those personalized medicines, it's definitely the heart, and we are the champions. I think we're probably the champions of it in the healthcare system. Others as well, but I think psychiatry has been actually quite good in psychology. So big data, moving on to big data. This is what the definition I've used for big data sometimes. I gave a presentation about it. And there's a bit of hype, right, about data. You got to call it big data now, even if it's your old data. So big data, that's Doug's definition. But here's, just to get us on the same page, there's the most common definition that you see is the 4 V's of big data. So volume is one. I'm just going to kind of flip through these pretty quickly. So the idea that we have more data coming down like all the time. Variety. So actually, most people would say in healthcare, when we talk about this in the big data world, we say that healthcare really isn't the volume yet. It's the Facebooks. It's the. I have a friend who does analysis on Virgin's cell phone data. So they capture information from every call, and it's terabytes of data. And our data is tiny by that comparison. So we don't really have the volume. We do have variety. People would say that we're getting data from lots of different parts of the healthcare encounter or lots of different types of information. Velocity, no velocity. We have to wait 18 months where people are analyzing a lot of data in real time. I think there is big data like in ICU where you have heart monitoring and people are using that. But I think in kind of in this room, how we're using data in our health services or clinical data, the velocity is not there at this point.
And you could add that with clinicians, the velocity is 0 because
it doesn't get back.
It doesn't get back to us except in very limited segments, like some of the prevention stats and all that. But if I want to know what my patient has recently had as medication dispensed and how much is left and how many pharmacies they've been to, I can't. The data actually exists, and as a researcher, I'll get to it in a year or two, right? Yeah. So I mean, that's a frustrating paradox.
No, I'm going to get to that too. So let me park them off that and move on. And then the veracity. This is where we got it really in spades, where the data quality is concerned or difficult to analyze. And I'll talk a little bit more about this as well, like that affects our studies. So here's the example, and this is the example that I'm going to use. This is Carl and Alan's study. Remember that foreshadowing that Alan's the new VP of quality at the hospital. But this study began, like Carl's an internist, right? And he was in the emergency department, and someone came in with a ruptured abdominal aneurysm. And, the ticking time bomb, and he was talking to the vascular surgeon and said, how could this happen? We knew about this patient before. And the surgeon said, this happens all the time. And so Carl and Alan looked at the data at the hospital, and they had 310,000 images, which they text mined. The screening for the text mine, like talking about the uncertainty, the screening from the text mine, and I presented this and say the sensitivity, specificity was 99%, the sensitivity was 99%, specificity was 94%. How is that? That's awesome. Well, did you know that 90% of those are false positives if you just use that text mining without verifying the data? So the veracity of the data is a big problem. But they got down to 771 charts or examinations that were incidental findings of AAA, that there's recommendations for follow-up, routine follow-up, so that find that sweet spot of the risk-benefit. So, you monitor these. But from the charts, only 14% from the discharges from the Ottawa Hospital in 2010 had mention of the AAA that was found in hospital. And
so can I ask you, Doug, in that context, whose responsibility would it be to follow up? Let's say the patient was admitted for whatever, like some accident, or it was incidental finding. Like,
I would take that responsibility on my shoulders as a family doctor.
Mm-hmm. The moment you have the report in the chart, you have an obligation to act on it.
Yeah, I would say that it's mostly us. It's shared, but I think it would be mostly us. And I would say you want to communicate that to the patient, and these days I would put, if the patient has some agency and capacity, I would put some responsibility on the patient as well. There's 15% notes on the chart that was discussed with the patient, and then 16% had follow-up. 2010.
So is that 16 of the 771?
Yeah.
Or is 16 of the ones where it was mentioned in the discharge summary?
I don't know actually.
Because that's much fewer
of the overall.
Right.
A lot of these people are getting, everyone's getting these. This was anyone who's had a follow-up examination, whether it was for another problem or whatever, we don't know, right? Like that, everyone's getting repeat stuff for, especially the hospital patients. But this is of those people that had recommendations for follow-up. This is the number of people that had it within the recommended time. So, I think it's a neat example, or neat is maybe not the right word, but, the idea of the ticking time bomb, and that I think that if this was our parents or us, we'd want to know that we have a AAA. And whether, you can debate the evidence of screening and, whatever, but at least you want to probably know, and you probably want to have some follow-up. And I think we may not, sadly, we may not be too surprised with this, disappointed, right? Hugely disappointed, but probably not surprised because, you've all been the residents doing the discharge summary, and you have no idea what's in on service, and the residents are the ones doing this, and we understand the problem. So even in their paper, they wrote down the solutions which have been established, flags for it, automatically generating reports, sending the patient's information. They talked about some of the evidence base around intervening on this, 2010, what has been done, nothing. And I think that's disappointing to them. But I think this is kind of the idea that the opportunity for big data the case study before this report was 14 patients, the follow-up of 14 patients. And now, using routinely collected data, you can follow up hundreds of thousands of patients. So the opportunity and the challenge of implementing the findings. And, I've talked, and they say, well, anyway, I think, we could talk about, but I could talk, that's one of the barriers, right? The barriers of this, there's a lot of barriers. And what I'm saying too is that with the big data, these algorithms developing much more complicated algorithms, and we're giving them decision support. Decision support has hundreds of these, and each one is a monumental task to, not a monumental, but a really challenging task to implement into our systems. Can we implement this sort of stuff into our systems in family medicine? No. I mean, we have a real, practically speaking, we have a really hard time implementing the findings that we have into our information systems or into our practice. So there's opportunity and there's the challenge. And so where are we with this? So I would say that this is kind of the view of one of the views of big data, putting big data first instead of the patient. But this was a talk from last week that I gave at the hospital. But big data, and then we find out findings from that. We're trying to pass that, incorporate that into practice, change at the bedside, and then keep that cycle going around. And it does work in some situations. Okay, this is another, I would actually argue I would make the case that precision medicine is big data, or big data is precision medicine. So I'm going to come on the side of that, and happy to debate that. And this is the example, this is a review of heart risk prediction tools. This is in BMJ this year. And these are the predictors that have been used for CVD prediction. And that's that actually used. It does not, all the risks are not there. And, you know, so when we're thinking of trying to get that personalized approach, the idea that knowing differences between people, is that helpful for how we do clinical care, risk prediction, risk communication, interventions, everything. So is this sort of information helpful for our conversation with or patients' conversation with themselves? I would argue that most of this can be done by the patients themselves, trying to get the patient centered. But if you want to incorporate this sort of information, you must have big data. And, or the idea that, say for heart disease, 100 people are at a genetic risk, going back to genetics, and it doubles the risk. You know, and in Ontario, 100 people. I would argue if you're one of those 100 people, that information is important to you. The only way that we could assess whether their genetic risk is important is by having 100 people. You have to have enough, you have to have the 10 million people, and then all the 100 people in there to be able to get that resolution down to a portion of the population which is quite small, or that this idea that multiple factors are affecting our understanding of that patient. So we must, if we're going to put a lot of factors in to understand that patient, we need big data. Now I think we can argue, do we need that? It's going to affect care. But again, going back to the idea of that 1929 doctor, I think good physicians always have done it. But can we bring in evidence to make it personalized now? Can we bring in the analytics to make it personalized? With the concern that that doctor in 1929 was not evidence-based. They were being personalized, but the information they need to be getting is not maybe as evidence-based. I'll pause there.
Yeah, so I'm this. So I just read a book called The Drunkard's Walk, which was very helpful for me because I never did understand probability and statistics, so it was helpful. But it's that piece about the randomness and the piece. So what I'm thinking is the values-based medicine. So the piece that comes in, you know, I spent half an hour talking to somebody about the risk of a false positive of a mammogram in the 40 to 50 year age group. And at the end of a half an hour, she said, well, I wouldn't want a false positive, but I want a mammogram. So, you know,
There's probably some other lady who wants the false positive.
but it is that piece about values-based. And I guess an issue I have with risks is always saying, if it happens to you, it's 100%. If it doesn't happen to you, you can only be 100% pregnant. You can't be 90% pregnant. So the piece here is the values as well. So it's the conversation. Yep. So I do not argue, disagree with the need for the evidence. Evidence is always changing. I've lived through the HRT stuff. So, you know, we know that it can change. So it is about bringing the evidence to bear but our understanding of it and our own values and making decisions about ourselves. So knowing your own family history, I know what my risks are. And it isn't what all of the, the screening guidelines talk about. So that's where the personalized comes in.
Yeah.
And I think it's putting those together
Yeah.
with the evidence.
Yeah.
So, and what risks are you willing to take?
Yeah, I think Sharon was next, but.
I just think that the big data is a tool bringing the experience of many to the individual, and the individual can do with that what they want. I have been talking about the value of reporting on performance to patients. Do you want to know how your doctor compares to others? And it really depends on the item, but over and over again, they're saying, I don't care if 90% say this doctor sucks. If my experience is good and mine is, I don't care, and they discount it. So it's a tool to bring in the experience of many, but there are some things that they seem to absolutely value the experience of many, and others that are easily rejected. And so it's a tool that will have great use, but in different, for different fields, for different people.
Yeah, I'm not arguing with any of this. Obviously it's, patient values, again, patient values, patient preferences are obviously key, but yeah.
I just wanted to share something that I heard, and it's along the lines of what Diane was saying about, so we need, yes, absolutely, we need the evidence, we need to have ways of explaining it to our patient in ways that are appropriate for the patient, etc. But James McCormick he's a pharmacist out in BC, and he actually spoke at Rib Rounds, I think about 2 years ago, or it was when we were still at Bruyère. And I don't know if you remember him. Anyway, so very interesting guy. They do this he and a family doctor do this podcast called Best Science Medicine, and really sort of very much evidence focused. And one of the, so we had a conversation afterwards, and one of the points he made is the evidence is absolutely important, and we need the data to produce it and to inform that. But the patient values, he said, if we were to do a study that incorporated patient values, and you would say to somebody, okay, would you can have a 3% reduction in mortality if you take this pill for the rest of your life. And some people might say, well, I don't want to take a pill for the rest of my life. And which means that they would have, on average, a higher mortality. He said, your study would show an increased mortality. But he said that would be absolutely acceptable because that is the decision of that patient. So at some point, we have to be clear about our own values. We're certainly, I think, often unconsciously pushing an agenda. And I think we have to inform the patients appropriately, but we also at some point have to let them go and let them make their decisions, even if it means that there's going to be higher mortality or morbidity or decreased length of life or whatever, right? So I think that's where the values come in. It's at a step that's further down the process, and we have to accept that. And
I hope I'm not, again, like this isn't inconsistent with what you're saying, right?
No, not at all, not at all. But I just want, to me, that really, when he said, you have to, if the mortality were to be higher, then that would
Absolutely,
be perfectly acceptable because
And this helps,
it would be
but doesn't this help
consistent with the
it?
patient values.
Yes,
And
but doesn't this help us inform that?
Absolutely,
Yeah.
absolutely. So this is great because it's an earlier upstream
And I want to
step.
get, and I want to get to some of this.
But the reason I'm bringing
it.
it up is because I think a lot of physicians, a lot of us would be like, oh my God, by no means do I want to, even allow anything that will, produce a worse outcome. But it's not a worse outcome if it's the patient choosing it. And that's where we need to shift, or some of us at least need to shift our mindset to say, this is the evidence, and once I'm confident I've communicated that in a way that the patient understands it, I'm just there to support you making your decision. The decision is really yours.
Let me go on.
Can I, Bill, I think
You go on.
No, I don't.
Because I want to get to this a little bit more, but,
go ahead.
or I want to continue the conversation,
This is starting a new topic, so I can hold the question.
Well, I want to get a little bit more into the patient. I haven't talked about the patient-centric part yet.
Okay, good.
All right, well, let's
And I haven't talked about risk communication yet.
The two quick comments.
Yeah.
First is, You should spell precision right.
Thank you.
It's a little bit off.
But
It's not very precise.
I was sort of struck by your original thing about the relatively poor follow-up.
Yeah.
For the AAA. That is exactly what we found in a couple of very large studies of what happens after you implement mass screening for depression for adolescents. And we did it in a whole bunch of clinics in Ohio, but I also looked at a big program at Group Health and at Kaiser in the States. And essentially very little happens as a response in terms of either follow-up or change in care. And the question is why? It's not, I think, that the doctors think depression is unimportant. And I'm sure it's not that they think that an aortic aneurysm is unimportant. Somehow, we don't have the technology that surfaces the information to the doctor at the right time and the right place in a way that they actually think about it in the time they can act on it.
Mm-hmm.
And so that none of this stuff is really going to work until basically, my opinion would be, electronic medical records start getting smarter.
Yeah, what I like about this is you're helping me, you're foreshadowing a bit where we're going with something.
Okay, great.
This is just, I'm going to move on. This is just, I'll go this here. Framingham risk algorithm, our risk algorithm. Old way, new way, bad way, good way. Framingham, 2,500 participants. They spend still over $10 million a year following people up. They have nurses flying around, and 6 categorical predictors. Our recent one's 200,000 participants, but 14 predictors, flexible, like splining things and spline interactions. We can, the data's there, $100,000 developed. We can update it online, paper-based, move it online, let people do it themselves, tailor the out. You can have now, instead of saying your risk is 15% or medium risk, you can present lots of different ways. Tailoring communication. So we have a paper that's just been accepted called Personal Risk Communication for Personal Risk Assessment. And if you can start tailoring the information, I think, as well. Like risk right now isn't, like heart disease, I can go on. Heart disease risk is, heart health is a relative measure that motivates people. And so it's showing effectiveness for uptake in statins. It's a relative measure. We don't like multiple resonance and decision support. But you have the alternative are things like the Gates diagram, 100 smiley faces, which again are paper-based historically. And we think that you can improve those quite a bit. And we're testing them. We have focus groups for all this stuff, looking at different focus groups online. I'll go about how we can evaluate some of this stuff. This is an example of ethnicity. So on the theme of heart risk assessment, UK uses ethnicity, and it was developed by the UK GP database. Came in here. There's a few initiatives, not only that, but it's in all their EMRs. So when they started off, 10% of people had ethnicity in their EMR, but the risk algorithm asked for it. So they did this massive data imputation to figure out whether ethnicity puts you at increased risk. And then now they have programs to support risk assessment. Everyone in the UK is supposed to have risk assessment for heart disease. And now the charts are full of information about ethnicity. And that's that cycle, I think. That cycle of big data where you can prove it, then you can assess and evaluate the risk algorithm, who's using it, is it changing practice, and even improving data. So the cycle of big data. This is Rick Van Winkle. I put it in here partly because I said, I've been practicing for over 25 years now. And I think that I could wake up, have gone to sleep 25 years ago, wake up today, and practice wouldn't be that much different. But my sense is there's opportunities or change in the future. So I think it's going to be different. What are we doing? This is just sort of a snapshot of some of this stuff. So we're building these algorithms, as you know, using the big data. But probably the 2 areas that we're doing right now are health behaviors and then the end-of-life frail people. So that's with the raw data, 1.3 million assessments, 400,000 deaths, and using that for a lot of, it began, Peter Tansbutro and myself began that because of this idea that only 30% of people are having some indication that they're receiving palliative care before they die. And we think a barrier is that, so I think we talk about, again, talk about patients, physicians being great value-based, right? And I'm going to challenge you guys now, because that discussion is not happening around end of life. We suck at it. And for various good and bad reasons. So our thinking is, take physicians out of it. Put patients first. Let them assess whether they're going to die or not. That the physicians can be a barrier in this discussion sometimes as well. Or begin the conversation with patients. Let the patients begin the conversation themselves. Most of this stuff can be done by the patients themselves.
Our literature on behavior change for better, I mean, the evidence of that is so poor. We know patients should engage in certain health behaviors to improve their risks. Planning, end-of-life planning, what makes you think patients will uptake a conversation or a tool about their death risk assessment?
Well, this is our research, right? We wanted, this is the hypothesis, that if we let patients be the center and their family be the center of that process, does that improve decision-making and use of palliative services or end-of-life services? That's our
Can I make a recommendation
Yeah.
for a book by Atul Gawande called Being Mortal? Very, very nice discussion around choices people make or are actually not really making towards end of life and that they should be making. Very, very thoughtful discussion.
Yeah.
So, you're talking, but I agree we suck at it. But one of the things is in our 15-minute visits, do we bring it up? So I had a resident when I was at North York. His project was to put it in the reminder for anyone over 65, consider an end-of-life end-of-life discussion, or I forget the other term, but and the uptake was improved.
Yeah.
So it's part of that's the reminder. And for me, it's easy. I just say, do you have a power of attorney?
Yeah.
And that's the beginning of the conversation because it's less threatening. But it's the training.
Yeah.
It's the reminder. And when do you start? And starting when somebody's about to die is probably not the place to do it. But but I agree with you that putting it patient-centered, there may be barriers, but it surprises me all the time when I ask that question. Oh yeah, I have one. Like they've already thought about it.
Yeah.
So we have to not assume that people don't want to talk about it.
No, they do. They want to. They don't have agency.
Don't know how.
Yeah, they don't have agency to talk about it. So, Kevin, what time do we have? Is it?
That's what I was trying to
I
show
know.
you.
Is it like 20 past?
Yeah.
In my sabbatical, we did a project looking at rural conflict-affected Africans with HIV and what it takes to get them to accept HIV testing and treatment. And they were, of course, being looked after by the witch doctors and Petit Chef and all these people. So it was a really challenging kind of like situation. But with the Congolese psychologists that were from that region, we actually had a lot of success. And so I think what we showed with this study we did, a qualitative study, was that people can have different lines of belief going on at equal times in their lives. And we actually all do as well, we forget that. So they can still believe in the witch doctor, but they can still believe there's a drug they should take for their medicine.
Yeah.
And I think it's going to be really important because as the lottery tickets continue to be sold, the people that are making a choice that really doesn't make any sense to me, but people, I see them, if I go to the store, you see they're constantly being bought. So that is one belief system that to me, you don't need to extinguish that to have success with what you're talking about.
No, yeah.
To move by these other frameworks.
Yeah, I'm trying to turn the table on you now. I'm saying that, make it patient-centered. Put the patients first.
But I just think that it's important for us not to get discouraged by which really is a lot of other influences in commercial advertising that we see around that is competing against some of our logic, I guess. So we need to somehow be able to enter into that game. Maybe patient-centered is a way to bring it in, because it just needs to be a competitive process. we need to believe ultimately some people will choose this for themselves, so.
So I think just a lot of our stuff, we are trying to look at technologies now a bit of enabler, like we've just talked about this morning or with e-consult. And again, like trying to use as enabler to put patients first, try to put it so that it can be, more personalized or taken into consideration. This is chest score. I'm going to just blast through because we've got 3 minutes just to show you what we're doing. But chest score, this is the existing end of life algorithm. 15 questions, 5 levels of whether you're going to die or not, instability. This is the predictive score for it, or this is how it looks. Just like 5 is your highest score and 0 is your lowest. And, hazard ratio of 11, pretty good. C-stat, not so good. Okay, that's what the actual performance of it is in terms of observed and predicted. Level 5, they have 6,000, almost 6,000 per 1,000 people dying in per person years. That's the predictability of it. Terrible.
So why is that? So it's data?
Because, well, I think data, I didn't show the correction for it.
It's bizarre.
So we just put time interaction, like again, the larger data, you're able to build better models. You put time interaction, the C-stat goes to 8.5, just time interaction. And because, and this doesn't consider, it's not too personal, 1, 2, 3, 4, 5, 6. And people are at different risk of dying for lots of reasons, and I don't have time to show you the beta site for that, but we're now doing focus groups on it and things like that. So it looks like this. Just go to the screen, it looks like this. Again, we don't know, but we're trying to make death not too grim. And this is our little handout that we're using to engage people. Personalized, like what is respect about? The tool is called Respect. Risk evaluation support predictions for elderly life in the community tool. We're just looking for the good acronym. And then in our little handout for it, personalized, what's unique about it? Personalized means questions are detailed and specific, providing calculations are customized for each person, as well as the language and content for the questionnaire is tailored to the user. So already you can go on and say, is it for me, someone I'm caring for, or my patient? To click on patient, you have the full-on language. Click on me, and the language is simpler. And again, you can do this very quickly in different languages, different levels of education, and we're testing all this out. And the questions are very, like Framingham, you ask the same questions for everyone. Online, you can fork this tremendously. So we think for most people, you can just ask 5 questions, get a good estimate. For the keeners or for the people of the outliers, then you ask 35 questions. And we're giving information back. If I showed the beta, we're giving information back every time you answer a question. Your survival time changes. Yeah.
Do you know about computerized adaptive testing?
This is bringing more adaptive technology into it.
Okay.
Yeah. Not full on, but already the preliminary, the next stage of the preliminary response. Yeah.
Okay.
I was just wondering, with the design of the tool, was it with patients? Like, I know you're doing usability testing, but did you have patients design what the questions were and what was important?
Yeah, we start with the questions actually. And then from that, and how long, and then we go back to, we use that to inform the specification of the model.
But were patients involved in the design of the actual tool?
They were designed, at this point, what do you mean design the tool?
So when you decided which questions to ask and how to ask it, were patients at the table making those decisions, so not as usability, like once the questions were decided?
Yeah, and so we use that to specify which ones we would consider looking at the model, and then evaluate that. We have, patient advisory committee, we have key informants, and we have focus groups. All three. But and then patient-oriented means calculator design for people and the caregivers. Results presented clearly in terms that this is what we're striving for, easy to understand, or test developing as well. Test easy calculation for in real time, conversion as a person completes the questionnaire. This is the site. We don't have time to look at it, but in the site too, we have multiple ways of presenting it. Kate's diagrams, 5 lines, numerical. Again, this was the example. this is the technology to try to reduce that. It never gets into the practice. So now, like the analysts at ISIS would export the models as predictive modeling markup language. Line Survey is the open source version of SurveyMonkey and things like that. So anyone on the team can create and adapt questionnaires, change the questionnaires. And then we consume that in a calculator engine that runs on the client side. And you can change the model and it automatically consumes that. You don't have to, so the usual thing is like it takes 6 months to get decision support to implement DMR. We're trying to kind of reduce that down to 6 minutes sort of thing. Make it automatic. And then already Heart and Stroke is using it. We have it on our website. And then you can do it for batch load it for, calculate it for the entire province and use it for different purposes. This is Heart and Stroke. So if you go to Heart and Stroke now, like that life expectancy is generated from that calculator engine on our website. Like they send us the risk factors, we send back the calculations. And this is our simple site, right? But we evaluate this. You can randomize this. You can present this in different ways. You can see what people click on. And because there's a million people using it, you have opportunities to evaluate in different ways. And so we've evaluated, that's that sort of personalized risk communication. This is very simple, right? But personalized risk communication for personalized risk assessment, evaluating all those metrics and see what people find them motivating, informative, what they actually use. And we have different metrics, both qualitative and quantitative metrics. And sort of the quantitative ones are things like, for everyone, we can see what they click on, whether we have metrics of like recalculations means they're probably more engaged. If they look at their detailed report and print it out, they're more engaged. So you can change the site and see how they interact. And this is what Google does, right? Like this is, I say, Google is running the most randomized clinical trials in the world. We're all constantly being randomized. And they get so much volume that they can, within minutes, know whether to modify their algorithm. That's the opportunity, some of the opportunities. Obviously, it's not qualitative, but you mix it, do mixed methods. This, when we published this latest one in August, we put the PML, we put everything online on GitHub to make it accessible. We say it's the first algorithm that is machine readable in the paper, so that decision support guys can go in and click on those files. They can use our APIs or they can develop their own, and try to make it all machine readable. So I think that's about it. That's just running.
Thank you. Thank you. We've got 4 minutes for. I know we've already had some discussions, but.
Done?
Yeah.
Great presentation, thank you. Where'd you get your big data slides?
Yeah.
Velocity,
Google. They're IBM. I give credit to IBM.
Okay, great, thanks. They're fabulous. I like to use them. And then just second, a general comment. I think there's a lot of this boils down to like a digital literacy. For both providers, for patients, it's about ways of helping people become more digital literate. I think understanding big data, where it comes from, how it's generated.
Yeah.
Okay. One of the things that I really like about this is that you're able to change risk factors status and then see what impact it has on your survival, right? So I'm a smoker today. What if I stop smoking? What if I'm not a smoker, right? So I think that's really nice. And what might be sort of a next step to think about is if the patient is actually selecting, well, what if I change my diet? It'd be really nice if they could be directed towards resources to, be directed to 211 and instructed to plug in.
Yeah. Right now, I would say, what I want to make the distinction too, we are not decisions, nothing that we're doing at this point is a decisioning. I'd say we're just risk communication.
Right.
Right? So
But,
I think we made that, I I think what we're doing is more, from our perspective as researchers, I think we may get into that, but I think what we're doing is we're trying to be a bit specialist in risk assessment, risk communication, and then letting heart stroke.
But I don't think what I was suggesting is decision aid. It's more of a,
Yeah.
Based on your risk factor, here's some information.
No, I know, but
Yeah.
we're risk communication.
Yeah.
We're not
No, I
providing
know.
advice.
Yeah.
We're letting heart and stroke do that.
Okay, well, maybe
Right?
that's the thing. Okay.
And, our site went down like, conflict, I forgot to do the conflict of interest. I don't have any conflicts, but we are getting a lot more commercial use and commercial interest. And, our site was massively hit by malware. It went down for a day. And then we get all these calls. We're using it in our clinic.
Oh.
And what's the matter? We have patients coming in, we need salt calculator. We have researchers using this in a lot of countries as well, like evaluating or incorporating it and doing more of that sort of stuff, or in practice as well. But again, we're trying to be, just the framing hand calculator, not at this point. I think we're moving more and more into, especially that kind of the evaluation of the experience of the communication and how to communicate it well. But then that leads on to the intervention. But knowing your health behaviors does not change your health behaviors in terms of life expectancy. But I think when we talked with Bruyère, I think that there is some interest in the idea that you can let the patient screen themselves for whether they should go into high-risk clinics that everyone's provided. And that's the intervention, not this.
Or print
I just want to say that
and
this is
bring
just
it to your
communication.
doctor.
Yeah, this is the communication, this is the risk assessment, it's not the intervention.
Got it. Yeah.
It's not the decision, it's not the intervention, it's not the education, it's not the message, it's just the risk, this part. But this part that I was just showing is just the communication. For end-of-life stuff already, we have stuff live, it's been live for a year. And for that stuff, we felt it was important to put resources, there's tons of resources, but we put a list of resources. The one we have it based on the nursing home study, and you can go, we cut it off at 95% 6-month risk of dying. It was like, at the highest risk categories, there's like 102 people and 100 die. And so we think the end of life is very predictable. Successance is for most people, it's a very predictable experience. And we cut it off because it was so high. You can go in there and you can see these massive high ones. So we felt it was important in that situation. Even before we do, there's these calculators out there, right? But we felt even before we can fully evaluate this and develop it, like that was just our knowledge
Ethically, you
translation.
had to address that.
We had to put
Our last question.
It does raise the whole issue around the values piece, because this is a predictor, and the challenge then is it's not just about the patient's values, it's about the people around them.
Yeah.
So, I have a patient in a nursing home and they want to do, want the creatinine and give them Tamiflu, and it's not helpful, and I'm wondering why I'm doing all of this, but we have different values.
Yeah.
And so the challenge is, it's not just the patient's values, and it's so important to be patient-centered, but when you have institutional values that conflict with the patient's values, we run into other issues.
Yeah.
But I really appreciate what you were presenting.
REB has restrictions on how we can recruit focus groups, so that's one reason why we're having the patient advisory committee, so that on that we're stacking with First Nations and Muslim and potential cultures where discussion about end of life is different, and trying to get a bit of diversity of input into it. And that is actually our patient advisory committee is being chaired by Jim Cowan, who is the Liberal Senate lead, both my patients died, and he's at the funerals for my patient. I know him from Halifax. He's a but the idea that the Senate is interested too, because it's all Senate agrees that we need to do more. So I kept on talking to Jim at all my parents' funerals and my parents' friends who were dying last year, and we kept on talking. So, Jim, let's make you want to be the chair of our committee. But Jim will chair it, and then we're trying to just get real ethnic diversity.
And Doug, you know that Danielle and I are leading a provincial initiative on patient engagement in primary healthcare research. So we've got a website, we're setting up a resource center. It looks like you've already well on your way in terms of engaging patients, but we are a resource, an OSSU resource.
Yeah. We get tons, we try to put these on line, everyone can use them, right? So we get tons of emails and
Yeah.
things like that too.
Right.
So there's lots of ways.
That's a good way to